All right. Well, we are right at 5 o'clock. My name is Alyssa Carey. I'm a PT based out of Portland, Oregon. I am a part of the S&P SIG, and tonight we are here with Paula and Candace to talk about lymphedema. Um, I would love to get started by having both Paula and Candace introduce themselves. Like, let us know a little bit about where you're from, your background, how long you've been doing this, and then we'll get started into the lymphedema side of things.
Candace,
Candace, you
you
want to
go
take it
first.
Sure, sure. Thanks, Paula. So I am Candace Alexander. I've been a therapist for about 13 years now. I'm from Kentucky, born and raised, and I have not left. So I just kind of stayed there. I work in a bigger city, but we're surrounded by rural cities, so I kind of have a good mix of everything. I've been doing lymphedema for 10 years now, kind of been highly specialized in it for about 5 of those 10 years. So, but yeah, that's kind of pretty straightforward, I guess. I don't really know how much more else to add on there. So I got my Lana about 5 years ago, which I found was, hugely worth it, getting ready for being a focused or CLT. So, and then I got my oncology certification just this last year. So
Congrats.
thanks. A lot of work, very worth it, but a lot of work.
Would agree, would agree. All right, Paula, if you want to
You
take the
ready?
stage.
So I'm Paula Stout, and I am originally from Missouri and now live in Northwest Indiana, which is basically Chicagoland, just close to Chicago. And we moved up here about 9 years ago. But I obtained my lymphedema certification about a year after I'd been out of PT school. I shouldn't tell you guys the year, but it was 1999. So I've been doing this for a very long time. And I got my LANA certification as soon as I could, which is, like a year after that, you have to accumulate hours. So I've been doing this for quite some time, but what lymphedema led me into oncology rehab because of, treating so many patients with, had been diagnosed with cancer. Not all lymphedema patients are cancer patients. Not all cancer patients are lymphedema, patients, but that's kind of how I got into it. And then I am also board certified in oncology. And I was part of that first cohort in 2019 because we'd worked for so very long to get that specialty certification through the ABPTF. So I'm now on the ABPTS board as the oncology rep. And so, yeah, I guess that kind of sums it up, hopefully.
Awesome. Thank you both so much for being here. We're really looking forward to learning from your expertise, both from the lymphedema side and then also how it applies to oncology. To get started, why don't we start off with an overview of the anatomy and physiology of the lymphatic system?
How in depth do you want to go?
Why don't we start off with as in-depth as you would go to explain it to a person that you're trying to teach this to. We can kind of start there, and then if questions bubble up, we can kind of look to the chat for those.
Yeah. Do you want me to take this one, Paula?
You can start.
Okay. Yeah. Might really appreciate your educator's touch in there later on. So when I am talking to a patient and trying to explain the lymphatic system, I pretty much boil it down to the lymphatic system as kind of your dump truck of your body. It's responsible for getting rid of all the stuff that needs to go and also helping regulate those kind of components to help us dictate our immune system. So lymphatic wise, we have lymphatics just underneath of our skin. They actually dive into bigger, deeper lymphatics that actually get to a pumping mechanism. We call it a lymphangion. And that pumping mechanism helps move that fluid into deeper, larger areas, kind of more central into the body. And then we eliminate it through our kidneys, essentially, after it's been processed back into the bloodstream. And that's kind of the bare bones that I think my patients kind of really prefer to understand, kind of gives them a general idea of what we're talking about without getting into the nitty gritty of tributaries and watersheds and all the other fun lingo we get to throw around when we're CLTs.
Awesome. I think that that is such a great overview. So that way we can kind of stay, instead of getting into the trenches, really kind of talk about what is lymphedema, how the anatomy kind of changes with lymphedema, or what is caused. Um, yeah, what causes lymphedema?
You just keep rolling.
So,
So the way I explain it to them, lymphedema can be multiple like types or multiple triggers, but essentially what happens is what the body can do in terms of maintaining that fluid mobility gets superseded by the fluid mobility. So in some cases, that is we physically have more fluid and it's higher, more than what the body can maintain. In some cases, the fluid is staying the same, but now we've damaged the lymphatic system and now the lymphatic system can't function as well as it would. For instance, someone having lymph nodes removed, from cancer surgery, that transport capacity is less than what it is. And even though the lymphatics may not have changed, we may now have dived that ability below the level of what's normal, what it should be. And then you have mixed combinations where we've had an increase in fluid, but also a decrease in ability. So, someone who's pretty medically complex, someone who is dealing with, multiple infections, things like that. But essentially, I try to explain it in that manner because it helps boil it down to the basics of lymphedema comes along because we don't have the ability to handle the amount of fluid. So the fluid is either higher than what we can do, and that fluid is high in protein. And that's the big difference between lymphedema and another type of injury. That high protein fluid, the lymphatic system, that dump truck is to get that protein out of the system and get the body into processing it. And when we injure that lymphatic system or when we demand more than what the lymphatic system can contain, that protein gets left behind in the tissue, which when a lot of patients come to see me and they're on a lot of fluid pills, a lot of them are reporting that, well, it helps a little bit, but it's not as great as what it is because the fluid pills are not actually addressing the protein. They're just addressing a lot of the fluid mobility, but they're leaving that protein behind. So they're leaving behind thick body parts, heavy body parts. So part of what we do as lymphedema therapists is we not only mobilize or improve the mobility of that system and kind of direct it around any traumatized areas, but we also work on getting that protein back out of that system. And there's cat number one. So
I think you teed up this question really well, and kind of alluded to it. What is the difference between lymphedema and other types of swelling?
It really, at least like I said, when I'm trying to explain it to patients, I'm trying to kind of boil it down to kind of the basics. It really is that protein. That's the big thing. When that protein gets left behind, that causes a complete change in how the system functions. I think many therapists would call it an inflammatory process because it now triggers a chronic inflammatory process. If I sprain an ankle, and I might have some high protein fluid in there, but if my lymphatic system is able to handle that ankle sprain, it can flush that fluid out of there over time. And I might have some residual puffiness long term, but ultimately speaking, my body's eventually able to deal with that fluid. If that is high in protein, it'll be thick, it can pit. The longer that protein goes on, the more it leads to physical changes in the tissue. So you can start getting fibrosis and things like that. For a person with an ankle sprain, they most likely will mobilize that fluid and get that fluid out of there fast enough. For a person with lymphatic either damage or consistently higher lymphatic fluid than what the system can handle, they are now looking at long-term changes. It becomes chronic. So that inflammatory system becomes more of an issue. We develop fibrosis, which creates increased girth of the limb, increased size, increased heaviness, and then also stimulates more inflammation. So it kind of becomes a vicious cycle. And our job is to try to break that cycle. I do try to encourage my patients because we actually can treat a lot of edemas like lymphedema. You just cannot treat lymphedema like basic edema. You have to go a little bit more advanced for basics, but all of the principles we apply to lymphedema, we can also apply to more kind of bare bones, ankle sprains, orthopedic injuries, and things like that.
So, and basically, lymphedema is a result of damage to the lymphatic system. So it's either a damaged lymphatic system or a compromised lymphatic system. So there are primary lymphedemas where someone's born with a malformation in the lymphatic system, and then there are secondary lymphedemas, which is what we're talking about when we talk about individuals with who have undergone cancer treatment where they've had lymph nodes removed. So you, like Candace was referring to, if you have an ankle sprain and you have a healthy lymphatic system, your body just kicks in what we call that safety factor, where the system just works a little harder and eventually gets that swelling under control. And that's why compression is enough, elevation, rest. But with lymphedema, you have damage to the lymphatic system. And that's where our whole treatment, which I think you have down later that we'll talk about, gets into our treatment process, where it requires the manual lymph drainage, where we want to reroute that fluid toward the healthy lymphatics. So the main difference is lymphedema is the lymphatic system is damaged in some way, and edema is just you have swelling because the system is overloaded.
Great. Thank you for those explanations. That's really helpful. This question may be one that we can kind of roll into too. So how is lymphedema diagnosed? Thinking about what is going to be the kind of clinical presentation that a provider may see that would refer them to a CLT.
So I'll start with this one because this is kind of the $1 million question. And I mean, as far as diagnosis, so what you said is very important. The clinical presentation is really what's the most important. And that's what we usually see. And, again, if we know that someone has had lymph nodes removed or they've had radiation or that sort of thing, then we know that, they're at risk for lymphedema. We can teach them what to do to reduce their risk and or avoid it. Or if they already have lymphedema, we know how to treat it. But unfortunately, sometimes what happens with those primary lymphedemas is those patients have been here, there, and everywhere. And they're like, my leg's swelling. I don't know why, and they kind of get the runaround. And unfortunately, that still happens. It's better than it used to be. But there are diagnostic tests like lymph scintigraphy and things like that. But those are not things that are done routinely. And so much of the time, it is very much a clinical, diagnosis that from what we see. And oftentimes we're the ones, right, Candace, where these people come to us and they're like, they finally sent me to you because, my legs started swelling when I was 14 years old and nobody knew why and because sometimes the onset is at puberty with primary lymphedemas. And I'm like, this is textbook case, in our head, but they've been around the world. And I think it's because there's not really a specialty in lymphology in the medical field as far as physicians, you know what I mean? And so, they sometimes or, they've been to cardiology, they've been everywhere, and they come to us because they have swelling. And then we really do kind of discern that, is it primary? Is it secondary? Is it lymphedema? Is it edema? And, one thing to know is that lymphedema is asymmetrical. Okay. It can still be bilateral lower extremities, but one's going to be worse than the other. You know what I mean? Again, that secondary lymphedema where we know the cause of it, we're going to know, for example, if they've had axillary lymph nodes removed, that arm is the one, that's going to be affected. But it is asymmetrical. So that's different than something like somebody who's in congestive heart failure or someone with chronic venous insufficiency, which chronic venous insufficiency often turns into secondary lymphedema because of that chronic swelling, that secondary damage, like Candace mentioned earlier, that fibrosis that happens over time that damages the lymph vessels further. And that is more of a lymph vessel issue versus a lymph node issue where they've had lymph nodes removed. So many times we're the ones that are kind of, diagnosing what the cause is and is it edema or lymphedema? Do they just need compression or do they need the full CDT, the complete decongestive therapy?
I think that this actually leads into this leads into the next question of what, from your perspective, the clinical application, what role does rehab play in management of lymphedema? We can even talk about, right? Let's talk about specifically about assessment of lymphedema. What are things that you're looking for as far as like objective measures and outcomes, and then also considerations for red flags and yellow flags?
Well, I think there's lots of things we're looking at. I'll start, Candace, and then because I want you to come in on those red flags, yellow flags, all of that, please, if you would. But as far as assessing, when we see them, of course, we're taking circumferential measurements. And we fortunately have clinical practice guidelines now within our oncology section for the assessment of upper quadrant lymphedema. Clinical practice guidelines, we can apply them to a certain subset of patients. So it doesn't apply to lower extremity. However, it can carry over to that. But we know that the circumferential measurements converted to volume. So we use this truncated cone method where we convert it to volume, are very, very valid and reliable in predicting change and, watching that change over time, because you're looking at the difference between the extremities. And so circumferential measurements are really, I think, the thing that most of us use the most. Now, we have things like bioimpedance, the LDEX, different things like that are really good for assessing lymphedema early on. So like in stage 0 or 1, it's not reliable for once you get into stage 2, because it doesn't take into account the fibrosis. So those are that would be how we, as far as measurements, okay? And then as far as subjective outcomes measures, we use things like the DASH, there's evidence that shows that it has been, a lot of our outcomes measures are so good, but they really haven't been tested in the oncology population. I keep going back to oncology, don't I? I know we're talking about lymphedema, but the DASH, has been, and there are others. There's a LLIS scale that we can use for lymphedema as well, that talks about function and that sort of thing. But I tell people this all the time, because sometimes they get referred to us and they're like, we're the lymphedema therapist. You know what I mean? And I'm like, they're like, well, do you treat this too? And I'm like, I'm a physical therapist first. You know what I mean? So we are looking at, aren't we, Candace, range of motion, strength, functional mobility, gait, all of those things. And that's the wonderful thing. Sometimes we get these patients that are referred because their leg is swelling and they've got balance issues. You know what I mean? Of course, our oncology patients, our patients who have undergone treatment for breast cancer, are shoulder patients. You know what I mean? So we treat all of that. So Candace, I'll let you continue with all that.
I mean, I don't really have much to add. I mean, you covered it quite well. A lot of it is a lot of hands-on. So if you have an interest in becoming a lymphedema therapist, but you don't really care about getting under the clothing, then this is going to be a rough role, because most of my patients, I'm very hands-on, I'm very touchy. I want to feel it, because there's been some wonderful articles recently really highlighting the different textures of fluids. So now we're not just talking about, are we pitting? Are we not? Is there a stimmer sign, which is the inability to lift the skin? Usually the back of the foot is more consistent in terms of that test. But the way I heard that test described is to have that, you have to have lymphedema, but you can have lymphedema without having a positive test. So it's not like you use that for early stage assessments or strongly mixed etiologies. But yeah, as far as it goes, it's a lot of hands-on, because we are looking for what's the texture of that fluid, what's the density of what I'm dealing with. Is it hard and firm, or is it woody, or am I dealing with kind of a very soft swelling? And just like she was saying, we really have to look at the patient as a whole. Like, I have a patient right now who will not be able to get compression garments on if I can't help her improve her hip problem. We're going to get the right one on, but we're not going to get the left one on until we deal with that hip flexor strain. So it's one of those that you do kind of have to be the physical therapist or the occupational therapist or whatever subset you have, but then you also have to like add on the lymphedema component. So it's also a lot of subjective. I talk a lot with my patients. We are going through a thorough history. My patients come in and they're used to the doctor spending 2 minutes and just saying, yeah, this is my problem. This is what's been going on. I'm like, okay, when did it first start? And they're like, well, how did it present when you first saw it? Like, what did it feel like? And we're really detailing that. And it's nice because considering how in-depth I have to go, they start to kind of really respond to that one-on-one, which is nice. And then they're really much more comfortable with me doing all that hands-on assessment, getting, if I'm treating a leg, I've got to go to the groin. I've got to assess the glute region. I've got to assess the groin region. If I'm treating the arm, I've got to look at the chest. I got to look at the back, and I have to touch on it. And like she was saying, we measure it because we have to quantify it essentially. So.
Yeah.
And that's such a good point about the touch in the assessment, because even if you look at the, like our clinical practice guidelines, which are huge systematic reviews looking at all the evidence, it still says, as far as the assessment of the tissue quality, that the most valid assessment is our hands-on, assessing, is it fibrotic, how is the tissue mobility? So.
That really kind of emphasizes the reason why rehab has kind of owned this arena of lymphedema. And Paula, to your point, when I said what role does rehab play in the management of lymphedema, you said everything. And I agree with you completely. It's not just the swelling, we're also looking at the mobility. So I appreciate you both for highlighting that, like, you can manage the swelling, but there are going to be other things that you may have to manage as well that are more in our kind of mobility tool set.
And I tell my patients, like, from the beginning, I say, you're not going to get rid of me soon. You know what I mean? Like, you're going to be coming to see me for a long time, because, you don't just get them to a point and you discharge them and you're like, you're fine. If you need me, give me a call. You know what I mean? You schedule regular follow-ups, because it is a lifelong condition that has to be managed. And that's many of our patients' first question, is this something I'm gonna have to do for the rest of my life? And you're like, yes, but the good news is, if you do this, this, and this, you can manage it. You can keep it from becoming debilitating and, reducing your function and things like that. And so, yes, it's lifelong, but we're in this together and you're going to do great. You just got to do what we teach you to do. So
Absolutely. Absolutely. Let's talk about those red and yellow flags. I want to make sure that we touch on this, because I think sometimes this is what we're nervous about is, can I treat this? Can I not treat this? What am I looking for? What am I safe to kind of proceed with?
So pretty much across the board, I am very fortunate in terms of time clinically. And most of my patients are coming from inside my own network. So I already have documentation that I can look at, which is really nice. I am looking immediately for any blood clots, infections, potential heart conditions, even the ones that have not been diagnosed. If the patient's been admitted to the hospital with multiple sessions involving related issues, but congestive heart failure has not been diagnosed, I'm usually talking to the patient and even potentially going to the cardiologist before they come see me if I have that luxury, which again, I work in a system where I can shoot them a message and they're usually getting back to me. Yeah, those are the big kidney issues become a problem. That's kind of a mixed bag. Many nephrologists will kind of greenlight a patient for therapy with kidney dysfunction, but you also have to be very clear, because I think a lot of physicians understand fluid in the concept of what we were teaching, I think 15 and 20 years ago, which is that fluid's going to make its way back to the heart. It's going to go through the bloodstream. It's going to link the kidneys. But I have to emphasize to my physicians a lot, this fluid is re-entering this system. It's going to bog down your red blood. It's going to impact the arteries, the veins, the heart, and the lungs. Can your patient's heart and lungs handle that? Can the kidneys handle that? And so those are really, when I see a patient, fortunately enough, given how long I've done it, it's now kind of automatic. My brain goes through it. But when I first started out, I would literally had a little checklist next to my computer where it was like, okay, can I rule this out? Can I check this out? Has someone proven this? So, and fortunately enough, a lot of physicians sending patients for swelling now, just specifically swelling, do recognize that we're probably going to need an ultrasound. We're probably going to need to rule out those blood clots. We're probably going to need to double check for heart conditions. So it is getting a little smoother than when I first got started. And hopefully Paula can attest to that too. But we still have people who come in for swelling who don't ultimately know. A lot of people coming to see me who are coming in for arthritis. I'm doing an assessment. I'm like, okay, I feel pretty positive we're dealing with this, but I can't quite rule out, a heart issue involved with this. You just have too many other symptoms related to that. So we need to go back and clarify that before I start care, because that's could possibly overwhelm the system. And my job not only is to help, but also not to hurt. So.
And I agree. And I think it's so important for us to, that checklist we have in our mind, Candace, that we do all the time. But I think it's so important to understand there's a difference between precautions and contraindications. And the only true contraindications to MLD, our manual lymphatic drainage, and compression are, which and compression is a little different, but for MLD are acute congestive heart failure, cardiac edema, or a DVT, an active DVT that's untreated, right? And so, I'm in an outpatient setting, so that's a little different. And I will get calls from our inpatient, like, hey, this patient's in here and they're really swollen and they've come in because they're in an acute episode of congestive heart failure. Can you come in and treat them? And I'm like, no, you know what I mean? But when we see them on the outpatient arena, you assess all the things you would normally in physical therapy. Like, does it look like a blood clot? I mean, what are the things you would look for? Does it look like infection? What are the things you would look for? You guys, know how to assess that. Does it look like, are they short of breath, abnormally? Like, you ask them those kinds of things too. Like, did they just get short of breath walking across the room? Okay, maybe this is a person that has a history of congestive heart failure, but they manage it, it's chronic because many people live with that. But if there's a sudden change, those are the things. And I've had patients like that before too, that I'm treating them, they're doing great. And then they come in one day and they're like, man, I just don't feel right. And I'm like, okay, I'm calling your doctor right, now, depending on what we assess. So I think it's constantly just looking for those things we already know to look for that would flag that type of, either congestive heart failure, cardiac edema, a blood clot, or an infection. We all know signs of infection, and we can do our treatment if they have an infection once they are on an antibiotic, and they need to be on that for at least 24 hours so that it's, that half-life of the medication and all that. So
No, and it was really a great point to also add, which you did, that we're monitoring this throughout, because unfortunately for most lymphedema patients, they're pretty complex patients. They've got other stuff going on. So there have been quite a few patients that have come in, and I know they're dealing with congestive heart failure. We're monitoring body weight. I'm monitoring the fluid, but maybe they're coming in and now they're having a different presentation. I've had a woman come in who was suddenly swelling in her hand, and she had never swollen in her hand before. I'm like, have you taken your weight today? No, I didn't take it. Well, let's take it and let's compare. And I'm calling the cardiologist. Her weight's higher. She's having swelling in new locations, and it's soft and watery. And that's not usually a good combination. So we're constantly assessing individuals kind of day to day as well. But fortunately enough, I can say with good confidence, it kind of becomes routine once you get past the overwhelming amount that you have to learn on the front end. And so you start kind of just comfortably getting, used to asking those questions like, oh, you've got a little red spot here. How long has this been going on? What's been happening? Did anything, did anything happen? And then you make those decisions. So.
Awesome. Thank you for walking us through kind of the assessment and things that you're looking for when you're seeing patients, especially over the span of their care. Can you walk us through how you treat lymphedema?
sure, I'll start and then Candace lead off. Basically, because I'll just kind of give the basics. How about that? That the treatment for lymphedema is called complete decongestive therapy. And it really is still the gold standard for conservative treatment, and a very conservative treatment for lymphedema. And it consists of 4 components. So there's manual lymph drainage, there's compression, which we'll talk about that a little bit because I know you want to know in the different phases. And then there's exercise, and there's skin and nail care. Okay, but the manual lymph drainage and the compression are so very equally important, I believe. There's tons of evidence out there now. There's discussion. We're revising our CPG of, is MLD, manual lymph drainage, MLD, is it, effective? But we know it is because we do it, right, Candace? I mean, we see it, you know what I mean? And but what manual lymph drainage does is it stimulates what Candace referred to before with our lymph vessels, those lymphangions. So when I'm explaining to a patient that our lymph system helps to clear out things and avoid infection and get rid of the junk in our tissues, is what I say. It's a one-way drainage system. So the difference is we have our heart as the central pump for our bloodstream, right? So it pumps the blood through the veins and arteries. So the veins and arteries are really just kind of like pipes, But our lymph system is a one-way drainage system where it picks up the proteins and the bacteria and toxins and cells out of our tissue and returns it to the bloodstream. And so those lymph vessels have their own little muscle pumps, and they work by responding to stretch. So when there's an influx of fluid into the vessels, which happens all day, every day, we don't know this, that our bodies just drain in 2 to 3 liters of fluid every day. It's picking up all that fluid out of our tissues, and it drains it into the lymph vessels, into the lymph nodes, which clean it up. Okay, that's where we have those little macrophages, those little Pac-Man cells that phagocytize those noxious substances and get rid of the bacteria and that sort of thing. And then it finally returns the fluid to our bloodstream. And then again, a simplified way that I explain it to patients is that then it dumps it into the bloodstream and our body filters it through the kidneys and dumps it into the bladder. And that's how we get rid of the fluid. And so, but the way that those lymph vessels move that fluid is they fill up with fluid and they respond to the stretch of the vessel wall, and that makes them pump. So they're doing that all the time. But fortunately, those lymph vessels are superficial in the skin. So when we apply this light manual lymph drainage over the skin, where we mobilize the skin, it stretches those lymph vessel muscle walls and it causes them to pump faster and work harder. So basically, we make the healthy part of the lymph system work harder to take up the slack for the part that's compromised. And that's how manual lymph drainage works. But then, of course, we need the compression to maintain that reduction and then further reduce. The compression helps to, again, maintain or reduce the swelling, but also to break down the fibrotic tissue. And then exercise is important because the muscle pump, helps work with the compression to move the fluid, but also as physical therapists, we're addressing any range of motion or strength deficits too. And then we're teaching them meticulous skin and nail care because, as Candace alluded to way early on, that the lymph system is our cleanup system. So it's part of our immune system. And so if you think about it, if your lymph system is compromised, your immune system in that area is compromised. So a little cut or scratch or, thing that you normally wouldn't worry about could be a really big deal because that system's compromised. And so we teach them that to help avoid infection. And there's much more to it. I'll let you go ahead, Candace, with the rest of it.
I'm trying to think of what you need me to go through in terms of more aggressive. So, because you kind of covered the kind of major aspects of it.
What about the compression? Maybe the bandaging and the then how the bandaging is different, and then the garments.
More detailed.
Yeah. Do you want to talk about the reductive phase versus the maintenance phase?
Yeah. So I try to tell, like when I'm explaining it to my patients, I tell them we have 2 phases. In one phase, my goal is to help you get small as we can get it. And then in the other phase, your goal is to keep it small, is kind of what I tell them. So reduction and maintenance. So our job in the reduction phase, especially if we're doing true CDT, true complete decongestive therapy, it's really compression bandaging. Honestly, very effective. The biggest struggle is in the day and age that we have now, when I say compliance, I don't mean it as in they are deliberately non-compliant. It is just hard to live life with your leg from your toes up, bandaged up, for someone who's working with kids and have family at home. Same thing with the arm. So there are ways that we try to make that a little different for them. But honestly, when I have a patient comes in who can do true CDT, within weeks, we're seeing drastic changes because we're going to take that that body part and we're going to wrap it in some supportive, usually foam, which gives us a lot of different things. We can increase the density of the foam to help fibrotic tissue areas, so it will help soften really well. Gives us nice support because we are doing very intense compression. I got to use a pressure monitor years and years ago while I was at one of the conferences, and my wrapping technique is consistently 50 to 60 mmHg or more for the lower leg. So that's a lot of pressure. If you think about, a 20 to 30 compression garment, you're looking at it like I'm doubling to almost tripling that in some places. So when it comes down to it, that foam is going to provide some support. And then it's also going to help as the person moves their body part, that that compression garment or that bandage is creating some resistance. So now as they move their calf and their calf muscle is expanding and stretching, it's now stretching against a wall, is what I tell people. So that wall is now encouraging an upward mobility, where the skin was doing that for a person before. Now the skin, after being swollen, is not able to provide that level of support. We are building a new support. We're building a wall. I'm reinforcing it for them essentially. And so by allowing them to do that, we're increasing that upper mobility out of the body part, arm, leg. We do that. We apply the same thing to the chest and to the genitals as well. But we just have to modify the type of bandage we do. We do the foam. We do sometimes a padded layer if they need like a little bit of soft padding. But then we also use short stretch bandaging, which every one of my patients will call an ACE wrap because it looks like an ACE wrap. But when you really give a pull on it, it's not going to move hardly at all. You will get a lot of pressure when you go to yank on it. So you have to be kind of diligent about wrapping it, because you got to keep in mind, we're not doing an ACE wrap. We're not wrapping it for dear life. We are trying to make a wall that's going to provide that resistance as the body part moves, which is one of the reasons why one of the yellow flags we were talking about earlier, that can sometimes be someone who is paralyzed because that body part's not being moved. We have to be really careful about how we apply that pressure because our whole system is really dependent on muscle pump action and activation and mobilization. So we do that wrap. Ideally, in the true CDT world, we would see them every day. I even have some patients who did this 20 years ago who are being seen twice a day. I wish that was an option in our world, but unfortunately it doesn't seem to be anymore. I've not been able to achieve it, but I see them every day. And then hopefully come the weekend, they have learned enough and they know enough to do some self-bandaging, or we have some sort of alternative method for them over the weekend. And we do that until we get that body part down as far as we go. The nice thing with the foams is I can constantly just trim those up and make a new nice fitting bandage for them until we get down to that nice size. And then we take them into the maintenance phase. And the maintenance phase is that I am looking on getting them a compression garment. It might be something with Velcro that maybe it's easier for them to get on. It might be a custom compression garment because maybe their tissue texture and their limb shape needs something specific to them so we don't risk damaging anything, or so we can encourage a consistent distal to proximal mobility of that fluid. Or in some cases, it can be an off the shelf. You do have the occasional person who can get an off the shelf compression garment on. That's what their body needs. And so you have this nice moment where it's like, okay, we can actually buy this almost anywhere at this point, which is nice. But yeah, there's a lot of differences. That's kind of true CDT. And then sometimes you have to modify it. Sometimes the patient can't come see you as often as you would like. Sometimes they don't have the ability to do the wrap, or the caregiver just cannot do that if they're helping. So there's alternatives to true CDT. I think most therapists would prefer to do true CDT, but when I can't, I'm often looking at, reduction kits, what they call like a Velcro and elastic kit. There's all sorts of brands and styles and shapes, but it does give my patient more ability to do it on their own. So if they can't see me 5 days a week, if I'm only going to get them once a week for, however many weeks that I can work with them based on their insurance coverage, those types of tools can be helpful. But I do always tell them, I would prefer to do this. If there's a way we can work this out, this would be my ideal. This is a really good alternative, but it's not gold standard care, just for them to be clear, because they'll get improvement. But compared to someone going and custom making a wrap every visit that completely fits their needs and their structure, you're just not going to get the same quality as something that's literally being Velcroed on really quick. So, but yeah, I hope that explains enough about that.
I think so. And I think you teed me up for another question. I know that this could actually take its own hour, but can you just introduce the Lymphedema Treatment Act and what that can potentially mean to patients?
Yeah, Candace and I are both so excited about this. This is something we've worked for so many years, and finally got it passed. And then last year I served on 3 different committees where we sat before CMS and said, okay, this is passed now, and you say you're going to cover compression garments, but what does that actually mean? And we're really excited with what we asked for and what they gave. But basically, Medicare, private insurances vary in what they cover. And Medicare, as of, I think that was 1998 when they passed the Women's Care Act, that they actually paid for the treatment for lymphedema, but that didn't include compression garments. They grouped compression garments into disposable bandages. That's how they looked at them. And so they wouldn't pay for them. And so, Medicare patients had to pay for their compression garments out of pocket always. So we've had to do so many things, try to get help from a, foundation. I mean, some of them can't afford it. So help from the foundation, help from, different things like that. So it was really exciting to get this passed, which says that Medicare then will cover compression garments. And then what we were able to work out last year. Now, again, this year it went into effect in January, and this year has been a mess. I mean, it's been good, but the DME suppliers are really kind of interpreting it the way they want to. They're also, there's been more of a delay in getting the garments, but it's okay. We're going to keep fighting and we're going to keep going for this, and it's going to get better. And we're going to meet with CMS again the end of this year, which it is the end of the year. But what we did get covered is they will pay for 3 compression garments per body part. So this was another thing. At first we're like, okay, they really need like 4 every 6 months. So that would be 8 a year. So what they came out with is they'll pay 3 every 6 months. So that would be 6 a year. But we said, okay, it needs to be per body part. For example, if they need an arm sleeve and a glove, we don't want that to count as 2, right? So they did that. I mean, we were just so excited because, I mean, we really had to go to bat for that, like 3 or 4 different meetings on that. So they'll pay for 3 compression garments per body part every 6 months. And then they'll pay for the nighttime garments as well. And that is 1 every year. Is that right, Candace? 1 every year. Yeah. And then 2.
I think it's every 2 years.
Every 2 years. Yeah. Sorry. I mean, you'd think I know. I do this every day. No, I'm just joking. But the nighttime garments are a different creature, but they're necessary for some patients. And that's another thing too with what Candace was talking about earlier with all the bandaging. This would again take it's another whole hour for this discussion. But if we see them early, especially if someone who we know has had lymph nodes removed, so they're at risk for lymphedema and they're just starting, we can often fit them with compression garments right away, and we can skip that bandaging phase. And so years ago, I mean, this was not the case. Every time, we would not get patients referred to us until they had severe lymphedema, but now we can kind of treat them early and do that. But so this Lymphedema Treatment Act is a huge thing, a huge win, right? A victory, I think, for us in this field, for those individuals of ours who have Medicare. And with Medicare replacement plans, they're a little different, and so it varies, and we have to jump through a few more hoops with them, but it's just great. We're just thankful that our patients are getting coverage for the garments.
And it's a consistent 80%. And I don't think I can explain the significance of that truthfully. Private insurances cover at very different rates, and they already have contracts with these DMEs. So when I have a patient who comes in who needs a pantyhose, that pantyhose compression garment, if it's flat knit custom, is going to be probably 7 different prices depending on their insurance. With the Medicare, once I have an idea of what the cost is for that garment, if I have a patient who got knee highs earlier in the year, I know roughly what that 20% is, because that 20% is consistent across Medicare. And then many patients have a supplement or an advantage plan, which oftentimes will pick up the rest of that 20%. And so again, like she was saying, I really don't think until you're in the world, I don't think you can understand how heartbreaking it is to have a patient who has Medicare, who is living, retirement check to retirement check, Social Security, and comes in and they're like, oh, well, I couldn't do this month because I needed to pay for gas to come see you. And then you're thinking, now I need to somehow get you $100 waist high compression garment, and I have no clue how to make that happen for you. So it really has been, you'll hear people say, and I'm often probably one of the worst of it, like all the stuff that needs to be done to make this better. But the fact that we've even gotten it started is a huge asset to our patients. And it's really a great jumpstart to things that can really revolutionize our care in this country for lymphedema care, because unfortunately, when it comes to compression garments, we have been behind compared to some of the other countries that have really built some of these programs.
Wow. Thank you so much for all the work that you've done, because that does make a huge difference for people just gaining access to something that they know they're going to need to help them in that maintenance phase of lymphedema management. So thank you, thank you, thank you. Kind of switching gears here, future focus. We're kind of talking about the future you've alluded to. You've set the groundwork for us, and that there's more work that we can do. How do you both specifically see the specialty of lymphedema care evolving? And I can give you a second question too to kind of qualify that a little bit more, because that's pretty broad. The second question is, what are you most excited for that's up and coming in the research?
So what I would like to see personally is I would like to see insurance companies be much more supportive of true decongestive, complete decongestive therapy, which right now has been a problem, and it's just the approvals process. We seem as therapists, because we are PTs and we're OTs and we're speech therapists, if you have that luxury in your state, we are seen as therapists. So insurance companies seem to treat us like that. So sometimes they'll look at a patient with lymphedema and I'll frequently get 6 visits. And then it's a fight to get anything more than that. So if I'm doing true CDT, I've used those visits within the first week and they're gone. And so we really have to plan a little bit differently, and that changes. So what my true intentions are for that patient, which I know would be the most efficient and the effective for them, I cannot do because of the limitations. And same things with, like, and again, not to be rude, we are getting better physician support than what we have ever gotten before. I have more physicians now who know about this than people who just come to me because the radiologist noticed they had some swelling in their arm, and they thought that might be worth looking into. So the physician support is better than wherever it has been, but also getting physicians to understand that this is an extensive process, and your patient going to therapy, that needs to be a connection with someone that that you trust to do those things. And I really hope as the CLT population gets bigger, we'll have more exposure in that world. Because right now, I've got some physicians who send directly to our offices because they know our care. But then I have other people who just like, oh, we Google searched you and that's how we found you. And it's like, we really need to have some sort of way. And I really hope in the future that we have a way for not only patients to find us fairly regularly, but the physicians to know where to go to get that information, and then to be able to provide that treatment. So the physicians can educate the patient on what's coming, so that that first day they have an idea of what we're about to do. Because most patients come in the door and they're like, I don't know, I'm here to deal with my leg swelling. It's been going on for a while and it's been a problem. The doctor says I need to treat it. I'm like, okay, well, let's talk about what we're going to be doing from today forward. And I mean the rest of your life. And if that's not something you're okay with, we need to have a conversation, because the physicians just in many cases seem to assume that, oh, you'll go to therapy, they'll take care of it. It's like, okay, we're not curing it. We don't yet have that cure. It'd be great if we do. I'd be okay being jobless if we cure lymphedema. I'm completely fine with that. But having that expectation made, and that's more of an education. I would love the word lymphedema to be something that most people are at least familiar with in concept and know how to get those resources to get that correct information.
Yeah, I definitely agree with that. And a couple of things you said, Candace, made me think too. It's I think everything in physical therapy, I think so much of the time, because I can say this to you all on this meeting, because we are in the physical therapy arena. I think so much of the time what we do is very much underestimated. You know what I mean? It's not known that, I mean, we are primary care providers as well, and that that it needs to be valued. And yes, Candace, I've said that for years. Like, when you see a patient who has been diagnosed with lymphedema, they are like, I never knew I had a lymph system until this happened, right? So it would be, great if, especially even just in the medical field, if it was more well understood. But I think that, as you said, where we're like, we're going to manage it, from here on out. I mean, this is a chronic condition and we are in this together, and we are going to help you be able to live better and to, optimize your function and continue, to slow functional decline and that sort of thing. And I think it's so empowering for anybody who, you know, might even be thinking about going into this area, because again, as we talked about earlier, many times these individuals have gone through so many different things and they've just kind of been ignored. Like, yeah, you have swelling, sorry, you have lymphedema, maybe get some compression socks at Walgreens or something, and so they come in and they see us, and I think one of the biggest things that we do too is we validate that with them. Like, yes, this is what you have. And guess what? Here's why. And we explain to them the things you had us explain tonight, right? We explain to them, this is why, and this is how your system works. And this is why I'm telling you to do this type of lymph drainage, because, you're not just, rubbing the area, hoping it works. You're activating those lymph vessels, and we explain to them how it works. And I think that just like everything in physical therapy, that is so empowering to individuals, because it gives them something that they can do, when they've been told there's really nothing you can do. And we're saying, yeah, it is something you're going to live with for the rest of your life. However, there's a lot you can do to live better.
Absolutely.
The
Yeah.
future of lymphedema, though, I'm very excited for. Paula could probably speak to this a lot more. She does have a little bit more experience than I do. But in just the 10 years I've been doing this, we now have bioimpedance in many breast cancer clinics. We are catching early stage breast cancer related lymphedema faster than ever. So now I don't have to wait for that person to finish chemo and radiation, and then the doctor, not to be rude, but the doctor is dealing with a life-saving technique. In their mind, lymphedema is something that can be dealt with after. But in my mind, this breast cancer survivor is now getting done with this life-altering treatment, and now they're dealing with arm swelling. So even if they get this great plastic surgery and they feel good about themselves and they're happy, they now have a permanent reminder of their issue following them from here on out. So the fact that we're starting to see an improvement in bioimpedance testing, other kind of components that allow LDEX, SOZO, all of that allow us to catch this early. Not only is that, like, breast cancer is a great part for it to get started, because breast cancer is one of the most researched cancers that we have right now in our country. But the hope is that we can then translate that data to other components, gynonc, prostate cancer, just early detection in general, being able for people to have access and know, okay, well, we're going to send you here and have this assessed. And by having this assessed, maybe we can kind of catch this before it gets to that stage 2 swelling, which is now permanent changes. Like, I can get someone down potentially if their body has that availability in it. But if they're at stage 2, they're already developing that fibrosis. They're developing that new tissue. That inflammatory stage is chronic. So that's going to be a long haul for them to get down. And I might not ever be able to make that extremity the same shape and size as the other side without some sort of surgical intervention to go in and deal with the cosmesis of it. So I'm very excited about the future of where it goes, because in just the time that I've had to see it in breast cancer, I'm really optimistic that people much more gifted than I am in research will be able to take that and translate that into other areas and really build that up for us.
I agree. Looking at the future, absolutely. That's exactly. You said you said it all perfectly. And the really cool thing too is, if you look at even future, like you said, like surgeries and things like that, we do now have the lymph node transfers and the lymphovenous bypass microscopic surgeries that are effective. And the really awesome thing about that is that, and it's growing a lot. There were only a few that surgeons that do that, and it is growing, but those surgeons totally recognize, like, if you go to see them and you're like, hey, I want you to do a surgery to fix this lymphedema, they're like, well, have you been wearing your compression? Nope. Okay, come back and see me once you're compliant with your conservative therapy. So they're really recognizing what needs to be done on our end, that that they're not just you're going to go in and patients think, oh, you're just going to do a lymph node transfer and this is all going to go away. And that those surgeons are very honest with them and saying, this may or may not work, first of all, but definitely you're still going to have to do all these other things that you do in therapy. So I think that is, I'm just stating or talking about this because you asked about advancements even in the treatment. And so I think those surgeries, those microscopic microvascular surgeries are getting better and better. Whereas, way back when I started, they were trying that stuff and it was not working, and so we've come a long way there. So I think there's going to be a lot in that area, but it's not going to eliminate the need for the rehab part of things, no matter how good those surgeries, get. So we're still going to, be needed in that area. And I think again, in that area, at least it's being recognized, that physical therapy is a huge part of that.
So far, anyone post-op I've gotten has been required to do as close to true CDT as possible before surgery. So yeah, I think that's absolutely amazing. Yeah, it's if that can bleed over into the other worlds of physician care, if we can start getting that with like vascular surgeons, and if we can start getting that with your rheumatologist and all these other places, we really do have a potential to get onto these things much more quickly, much more effectively, and before that person reaches that very late stage. And that's what we're trying to avoid more than anything.
I want to open this up to anybody who has questions, because I know we are coming up on the top of the hour. But I did have a question that was sent to us earlier. It was any considerations for exercise with lymphedema? And hopefully this will give people time to enter questions into the chat too, if there is a question or two.
So if the person does not have anything else that you're specifically exercising for, it's really about movement. I try to tailor it to my patient and their interest. I have a couple ladies right now who are super into yoga. So we're looking up YouTube yoga videos to kind of what will give them good diaphragmatic breathing and big motions and really encourage. And that's got them excited. And then some of my people who are, for instance, desk workers, they just have to be able to do something while they're reading emails and on conference calls and things. And so we're just trying to get them moving at the desk. So exercise, at least off the top of my head, I don't really know of any like pitfalls you can really hit, except for just giving something the patient doesn't want to do. If you don't make it so they want to do it, they're not going to do it. And as Paula said earlier, exercise is one of the critical points, but I also find, at least with the people that I work with, myself included, not just, I'm not saying coworkers, but in the world of lymphedema therapy, my coworkers there, exercise is probably something that we kind of push into the corner because we learned it in PT school. And so you should know it. So we don't really have standards on, okay, if you're dealing with this type of lymphedema, we need to be doing these exercises. So it's kind of left per person. And I find, at least in my own practice, sometimes I can get a little bit lazy. And then about 2 visits and I'm like, oh, we really need to address your mobility. We really need to start walking, being active, working our calf pump, getting our hip flexors moving and things like that, deep breathing. And so I find that, yeah, there's at least not anything specific that I can think of. Paula might be able to find or expand on that a little bit, but it's really getting something that the patient's interested in.
Yeah, exercise is so important. It's what we do, right? As physical therapists, and it depends on their diagnosis. So, I keep going back to the oncology end of things, right? So the breast cancer related lymphedema. And so, very importantly, those individuals, we do incorporate in the beginning, stretching, like low load, long duration stretching. So because they're going to have that scar tissue tightness and that sort of thing. Of course, if we're talking just about lymphedema, they need that muscle pump. But then we're doing scapular strengthening and that sort of thing. And then when they're lower extremity, definitely, just even ankle pumps. We can't underestimate the value of good old ankle pumps, right? And they're so important when they have the compression garments or compression bandages on. So those are important. And then progressing to, standing exercises like marching in place, and, because then we're working on balance and strength. So I think just incorporating what we know as PTs, along with this lymphedema treatment.
Thank you. There is a question. It says, I'm on the inpatient side and often have patients post-op axillary lymph node dissection or lymph node dissection related to colorectal or prostate surgeries. Do you think on the inpatient side, we could do a better job of educating on potential lymphedema and swelling?
Yes. I think this is the hard part though, you know what I mean? If whether or not they get referred for that. And this is a great, I love this question because as Candace said, because breast cancer is the most researched, type of cancer, we have so much evidence of, our prospective surveillance, which again would take another couple hours to talk about, but and things like that, where we want to see people early. And like Candace alluded to the bioimpedance testing and the SOZO and the LDEX and all that initially. And so we do that. But unfortunately, even in that case where we're doing this early on, they don't get a ton of education before they're discharged. And this is something that it's specific to where they are. It's specific to what the physicians order. And so absolutely, even if we could just teach them some simple exercises and most importantly to say, hey, here's something you need to know about, educate them. That's why I say we're educators, right? Educate them on the possibility of lymphedema. This is what could happen. This is what you need to do. And by the way, there's something that can be done about this because they don't know. Oftentimes, you see people, I always say that this is the best thing, when they come in and they're like, I didn't know you were here. Like, I knew I needed something, but I didn't know there was something that could be done. So I love that question, Lauren, because that is so much what we need to be doing. And so how we can incorporate that, I mean, you guys, take that to your place where you work and say, hey, you know what? Let's talk to them a little bit about it and let them know that there's something that can be done after they're discharged from inpatient. Or maybe let's get them, and we try to get that with our hospital organizations to where like to have standing orders, to be referred to outpatient therapy. It's difficult. It depends again on the physicians and whether or not they're willing to do that. Don't you think, Candace?
Yes, I actually am very, like I said, I'm very fortunate. I know that. I'm aware. I'm very blessed. I actually work in a clinic where the physician is fully on board. So I actually get to do pre-surgical education. And it's kind of ironic that literally just yesterday, a woman was coming in and we did a bioimpedance test and I did a full assessment of her arm out of concern. And she just said, she's the way she's like, I'm just glad I knew it was a concern. Like, I'm glad we caught it early because I would have never thought this could even be a thing. And so even if as the inpatient side, that patient is not fully focused on lymphedema, that's absolutely okay because the more they can hear that this is a potential, the more they're looking for it. And the more they look for it, most likely the earlier we're going to catch them. And I try never to tell my patients that by catching it early, we're going to make it go away because there is a potential with that early stage 0 that with compression, we might be able to actually improve it so much that we can bring that risk back down. But I do try to tell them my goal is to catch it so early that we can keep it stable and not have the body parts be different sizes as much as possible, not have it impact you day to day. I even wear a compression sleeve when I do this education to show them that they're a little bit cuter than just the beige sleeves are now. So we have designs and patterns and all this thing to kind of make it a little bit more acceptable. So it's wonderful that you're thinking that route and I greatly appreciate it. And if you can just kind of spend a few minutes, just so you know, you've had lymph nodes taken out, that does slightly increase the chance of swelling. Please be on the lookout for these symptoms and please call these people if you develop symptoms. You have no idea the level of impact that's making for your patients. I guarantee you multiple patients will call a therapist. It might not be you, but they'll call somewhere and be like, hey, I was told this was a problem and I'm a little concerned. Can someone check me out? It will happen. So excellent question. And please, dear Lord, do it. It's amazing.
Because they're being bombarded with so much, you know what I mean? And so even if the physician said, hey, just so you know, lymphedema could result from this. I'm going to take out some of your lymph nodes. You could get, lymphedema, you know what I mean? Or even if the nurse then discussed it with them, and even if they have heard it, if they hear it from you, it's one more time they like, okay, that must be important. Because again, your focus, their focus is on getting through this. What treatment do I need to do to save my life? And so all this little extra information over here, like, oh, you might get lymphedema, oftentimes it doesn't process, it doesn't stick, because they're going through so much. So if they can hear that again, on from others, I think that is very important.
If you have the luxury, it also might be worth seeing. I know some medical record systems, you can do like a visit summary. If there's something that could be chucked in there to where they have something on paper. I mean, American Cancer Society, National Lymphedema Network, a lot of places have some great, very basic resources on it. The issue that I frequently run into is when they've heard it from one person, they've Google searched it. And then they're coming and they're like, oh my gosh, I'm going to get this. And they're very emotionally upset and distressed at that point. And then I'm talking them down. I'm like, actually, the risk is lower than what you're concerned about. It is a possibility, but we're going to avoid getting that huge leg. But so just any resources, or like I said, just the conversation, absolutely wonderful. And thank you so much for doing that. If you do, that's absolutely amazing.
There's a follow-up from that question. It says, I also wonder if you have any tips on how you have changed your education or treatment the more you've learned, and how you've improved adherence and confidence with exercise mobility for people with lymphedema.
I would
You want to
say,
go first?
I'm sorry.
I was going to say you go first.
Oh, perfect. I would say the treatment has been more of a change on me than it's been about my approach. I now spend a lot more time than what I used to, because I feel like sometimes as therapists, we become productivity machines, essentially. It's all about that productivity number. And if you work at a clinic where you don't have to worry about that, great, that's amazing. But most of the clinics I've been in, productivity is a number, and I need to meet that number in order to prove my worth, even though I feel like I'm plenty worth it. But as far as it goes, I feel like sometimes I can put that ahead of my practice. And so really about 7 years ago, I really try to sit down and just like, I need to get more in touch with my patients. I need to know their family. I need to know their home structure. I need to know their personal life goals. I need to know what we're really searching for, because halfway through care, finding out, oh, I'm going to the Bahamas and I'm probably not going to wear this, when I go, that's not going to really fly as well. So a lot of it has been more a change in me as a therapist to kind of make sure that I know what best practice is and I know what it needs to be, but necessarily my patient might not be open to best practice. I might have to make changes and modify. And I might not want to do that, but if I do and that creates some sort of compliance on their part, I'm treating them to the best that they're allowing me to treat them, but also B, I could possibly even encourage them more with more success to do it the actually true complete decongestive therapy treatment. So it's really been more of an internal reflection that's really changed in my treatment. It has resulted in improved treatment for me, but that's kind of the big thing that really took over a few years ago.
And I always say, I always go back to this, that it's like everything we do in physical therapy. What I'm getting ready to say is that, really you learn, you understand your patient, like you alluded to, Candace. And so, what are they going to be the most receptive to doing? I've always been a huge proponent of giving individuals exercises that accomplish a lot of things in one exercise, right? Because we know how we're even ourselves, right? If I give you 30 exercises, are you going to get them done every day or not? And so really trying to go, okay. And I will reiterate to my patients, even as we start adding exercises, I'll be like, don't forget, these are the most important. If there's a day you don't do anything else, make sure you do these two, and that sort of thing. So I think it's physical therapy from that end of things, but definitely I've learned a lot as I've gone along. I think more in just kind of being able to read that with individuals as to what is going to be the best thing for them. And it goes along with, you think about my marathon runner versus my patient that's sedentary, and again, I go back to oncology treatment, who's now undergoing chemo. You know what I mean? That marathon runner, I'm not going to be like, well, just walk 5 minutes every day, right? I mean, we're going to be at this level. Whereas my sedentary patient, I'm like, okay, every couple hours, I want you to get up and, walk around for 5 minutes. And, it's that same with lymphedema. And the other thing with lymphedema too is just those simple things. Like I said, the ankle pumps, the movement, just like if you don't do anything else, at least do this. So
Also, I'm starting to see, at least in my area, I don't know nationwide, but Silver Sneakers has actually paired with a couple places that offer aquatic therapy. So I probably have more patients actively in participating in aquatic therapy. So I've actually started, as I'm having this education session and we're switching into that long-term self-care, a portion of my education sessions, these are the community resources we have available. Is any of this of interest to you so I can help you get situated? Do you have an interest in joining a gym like Access? Do you have an interest in doing a group class with this group or this community or support group? Because especially in the world of cancer, support groups are a very common thing, but it's also like something like aquatic therapy. So I even have some patients that even though I don't perform it, I actually happen to have worked with a person who performs it in my area and I know what they do. And so I'll frequently be like, oh, is that an interest? Okay, once we're done here, let's get you there and then they can teach you what you need to know and then you can transition that into your own care. So yeah, I it's been really interesting to see exercise evolve in lymphedema care as more opportunities have become available.
That's awesome. I think I'm going to start looking for aquatic versions of Silver Sneakers. Thank you for that. Um, all right, it is a little past 6 now. I wanted to make sure that I'm being respectful of both your time, Candace and Paula, and everybody else here. Thank you all so much for joining us today. And thank you so much, Candace and Paula, for sharing your expertise with us. I know I learned a lot and I hope everybody else did too.
thank you for having us.
Yeah.
Yeah, thank you. If anyone looking at this has questions or an interest, please let us know. I'm sure like Paula's door has always been open to me, so I can't imagine she's going to close it on you all. But as far as it goes, lymphedema therapy is one of those things that I think it's probably the most rewarding thing I felt compelled to do as a student. I got to see it and I kind of fell in love. And I feel every day, even though I can have a horrible day at work, an exhausting day, and I'm tired, I still feel I'm very happy with my role in life, but it's something that you have to have a passion for. So feel free to reach out to someone with a CLT if you're kind of questioning if you have an interest in it or not, and truly ask those questions. You will not offend us because we all know how it can be exhausting, but it can also be so rewarding. And I really truly, when my younger people come and join our clinics and they're really excited about lymphedema, and then we get about 3 days into them kind of training with me and stuff, and they're like, oh, this is not at all what I thought it was going to be. I'm really glad we didn't pigeonhole them into a career choice or a possible job choice that they're not going to be happy with. So please reach out to someone if you do have an interest. I can't really think of any lymphedema therapist that's going to be like, I'm too busy for you, because we are such a small population of people. I don't think there's no competition between us. Like, why have competition? There's not that many of us out there. So we would love to help motivate or help give encouragement to anyone who can need it. So
Thank you. If anybody was to want to reach out to you, how is it best to be able to reach you? Is it email or any other way?
I would say email. Do you want me to put that in the chat now? I don't know if there's
That
time
would
for
be
that.
awesome. Oh yeah, absolutely. Thank you both so much. I agree with you. I think the community of lymphedema therapists is so small, and we're better when we have community with each other, even if it's not in our same town. So thank you so much.
No, thank you for doing this. This was a great idea. I really applaud it, and I really hope to see this grow. This is amazing. What a great job on y'all's part.
Thank you so much.
Thank you. I think I got my email in there. So yeah, definitely. Please. Yeah, I was just looking to make sure I typed it in correctly, but yeah, definitely please reach out. We need more, and we would love for you all to join us in this wonderful rewarding field.
Yeah.
Imagine what could change with that Lymphedema Treatment Act if we had an army of therapists.
Oh my
Yeah.
goodness, the beginning. This is just the beginning.
I know.
Yes, and then we're going to be recruiting you to help.
Oh, well, thank you all so
Thanks
much.
again.
And I
Keep
hope
up the good
everybody
work,
has
you
a good
guys.
night. Thank you.
You too. Thank you. Bye-bye.
Bye.